Hi and welcome. So we'll be looking at the management of dehydration in neonates. Dehydration in neonates is a dangerous condition because newborns have high fluid needs, immature kidneys, and limited physiological reserves. They can deteriorate rapidly, progressing to shock, electrolyte imbalance, seizures, or death. Common causes include diarrhea, poor feeding, vomiting, fever, inadequate breastfeeding, and excessive insensible losses like through sweating. So the aim/objectives of management of dehydration is to restore circulating volume and correct dehydration, to correct electrolyte abnormalities, especially sodium and potassium derangements, treat the underlying cause, which could be sepsis, diarrhea, or inadequate feeding, prevent complications such as shock, acidosis, renal injury, or seizures, and finally to prevent recurrence. So you assess ABCs, that's airway, breathing, circulation. You keep neonates warm, that's you prevent hypothermia. You weigh the baby to calculate the fluid deficit. Check blood glucose, that's to treat hypoglycemia if it is present. You insert IV access, which could be intraosseous if IV is difficult. Monitor vitals continuously, such as heart rate, respiratory rate, perfusion, and temperature. Strict intake output charting, that's urine, stool, and feeds. Evaluate for signs of dehydration such as sunken eyes, depressed fontanelle, poor skin turgor, lethargy, and reduced urine output. So move to classification of dehydration in neonates. We have mild. Here there is 3 to 5% weight loss. Moderate. Here there is 6 to 9% loss. And severe. Here there is greater than or equal to 10%. It often presents with shock. So what are the fluid used in neonates to rehydrate? We have 0.9% normal saline for initial resuscitation. There's Ringer's lactate used with caution. 5% dextrose plus 0.45% normal saline or 0.18% normal saline as maintenance fluids. Avoid plain 5% dextrose alone, hence there will be risk of hyponatremia. So we'll be looking at the management based on severity. For mild dehydration, if the neonate is stable and can feed, continue breastfeeding/feeding the baby frequently. Here, oral rehydration solution may be used in small amounts, 5 ml per kg every 30 minutes, gradually increasing. Monitor urine output, weight, and hydration status. Next is moderate dehydration. How do you manage moderate dehydration? This requires more structured rehydration. Give IV fluids, preferred in neonates because oral intake may be unreliable. Calculate fluid deficit, that's percentage dehydration times weight of the baby in kg times 1000. For example, if there is 8% dehydration in a 3 kg baby, you do the 8% divided by 100, that's 0.08 times 3 kg times 1000 will give you 240 ml deficit. Replace this deficit over 24 hours along with maintenance fluid. So you divide the deficit into 2. So it's 240 mils. You give the first 120 mils during the first 8 hours, and you give the remaining 120 mils during the remaining 16 hours. So for the maintenance, you give half the deficit plus maintenance in the first 8 hours, remaining half in the next 16 hours. Use 5% dextrose in 0.45% normal saline or 5% dextrose in 0.18% normal saline for maintenance and deficit replacement. Monitor urine output, weight as daily, electrolytes every 12 to 24 hours. Signs of overhydration such as edema, puffiness, and rales should be watched out for. So next is management of severe dehydration or shock. This is actually an emergency situation. The first step is to restore circulation. You give 10 ml per kg bolus of normal saline over 10 to 20 minutes. Reassess. You may give second bolus if still in shock. The next step is to correct dehydration. After stabilization, calculate the deficit and give as we did in moderate shock. Moderate dehydration. The next step is maintenance fluids. Here, neonatal maintenance fluid requirements are: if the neonate is a day old, you should give about 60 to 80 ml per kg per day. Day 2, you give 80 to 100 ml per kg per day. Day 3, you give 100 to 120 ml per kg per day. And day 4 onwards, you give about 120 to 150 ml per kg per day. Use dextrose containing saline, not plain dextrose. Always remember this. The next step is to correct electrolyte abnormalities. Here, if there is hypernatremia, you correct slowly, less than 0.5 milliequivalent per liter per hour. If there is hyponatremia, raise sodium slowly to avoid brain injury. So we'll move to the management by types of dehydration. So if it is isotonic, which is the most common, you use the standard rehydration regimen we have discussed. If it is hyponatremic, you avoid rapid sodium correction. Use normal saline or 3% saline only if severe symptoms such as seizures. If it is hypernatremic, it is usually very dangerous in neonates. Rehydrate slowly over 48 hours. Avoid rapid reduction in sodium to prevent cerebral edema. So let's move to the management of complications. If there is shock, do urgent fluid boluses. If there is hypoglycemia, you give 10% dextrose bolus, 2 ml per kg. If there is electrolyte disturbances, you correct cautiously. If there is acidosis, treat dehydration. Sodium bicarbonate is rarely needed. If there are seizures, treat with glucose first, then anticonvulsants if needed. If there is renal failure, adjust fluids, consider nephrology review. So what's the follow-up and prognosis in the management of dehydration? Most neonates improve rapidly with correct fluid therapy. Monitor weight, feeding, hydration status daily until stable. Recheck electrolytes 12 to 24 hourly. Educate caregivers on proper feeding and early danger signs. So What's the patient education slash counseling in dehydration? Explain to caregivers importance of exclusive breastfeeding, signs of dehydration such as poor feeding, reduced wet diapers, fever, sunken eyes, and lethargy. To seek help early during vomiting slash diarrhea or poor feeding. Avoid giving water or herbal mixtures to neonates. Thanks for listening.